This is One-on-One. I want to introduce you to Dr. Randy Deger. He is a Gynecologic Oncology Specialist here at Virtua. Dr. I want to welcome you. Actually, we're at your place, so you can welcome us.
Welcome.
Doctor, we have technology behind us that you're about to explain to us. Now, talk to us about your specialty, first of all. Who do you treat?
Well, I'm originally trained in OB/GYN and have a subspecialty in gynecologic oncology. So the majority of my patients have cancers of the female genital tract.
Now, the technology we're talking about here, this robotic-assisted surgery, right, that we're talking about here, this Da Vinci, if you will, surgical system, it's changed dramatically how you treat your patients.
It has. Clearly, the laparoscopic technique, or the minimally invasive, has been around for quite a period of time. The FDA did approve this technology for GYN use in 2005, and since that time, we have used it in many, many different circumstances for GYN patients.
Now, before you go over there and actually give us a demonstration, Doctor, who is it, or which women are the best candidates, if you will?
Well, because of the small incisions and the population, which is becoming larger, and particularly endometrial cancer patients tend to be larger patients, this technology...
No, that's endometriosis, someone with endometriosis?
Well, endometrial cancer first.
Okay.
They tend to be larger patients, and this technology has helped them recover quicker, smaller incisions, avoiding large, big incisions, making actually their return to life much more rapid. The disease that you're speaking of, endometriosis, can be a very, very difficult disease to manage surgically, and the majority of those patients will oftentimes require a large incision. However, with this technology, with expertise, it can be done through a laparoscopic approach, if you will, or a robotics approach.
Am I going over there and showing us?
Absolutely.
By the way, as the doctor goes over, I just want to remind folks that he's in charge. The doctor is in charge. Sometimes people say, oh, wait a minute, the robot's going to do it? No. The doctor is in control of the robotic equipment, and as he does it, he's going to show us how this works. Now, the doctor, as you can see with our camera work, is moving. Doctor, describe what you're actually in control of right now.
So, Steve, I have control of 4 arms, and 3 of the 4 arms have instruments, and one of these has a clutch. So I'm always in control of 2 of the 3, as you can see. In addition, I have control of the camera, which allows me to move in and out from the surgical field.
The camera's right here, right, team? Right? Doctor, just to give a sense of scale, is it okay, I don't want to hurt myself here, is it okay if I stick my finger in here to give a...
Absolutely. Come on over here over this red cone, Steve, and I'm going to hand you this rubber band.
Where can I come in, over here?
You're coming from the back here and just come right near this red cone.
Is that good?
That's perfect. And as you can see here, our audience can see the relative size of the end of this instrument compared to the rubber band and your finger.
That's fascinating.
Now, because there are several things about the robot which is different from laparoscopic. One is you can readily see how the instrumentation articulates in such a way as my wrist does. And this gives us a much better ability to move into tight spaces, close anatomy, as you can see here, for example, moving things over in this direction. When you have straight laparoscopy, the instrumentation is defined in 2 planes, in and out and sideways. That's it.
No wrist?
No wrist.
So define that again, doctor. So laparoscopic technology, not like this, does not have the wrist capability.
That is correct. And limits your ability actually to get into those tight spaces, which is really the big advantage of robotic surgery. In addition, you can see that I've had 3 cups of coffee this morning, and these instruments are not shaking at all. And one of the things that the robot does is it takes the shake out of the hand. So the tremor is absolutely reduced to nothing.
It takes the shake out of the hand?
The tremor, yeah. There's an inherent tremor which surgeons tend to have sometimes. As you can see, I'm absolutely...
You're doing that on purpose?
I'm doing that on purpose, right. But you can see here, as I'm holding this right now, you don't see any shake at all.
Because?
That's just the way the technology has been designed. Now, the one disadvantage is, and this is what you have to get used to as an operating surgeon, and we learned this during our training, is that you can't feel how strongly you're either touching something or how weakly you're touching something. So, for example, when I pull on this, I don't have any what we call haptic response in my right hand. I am pulling on this, but it feels the same whether I'm pulling way up here or whether I'm just pulling a little down here. So a lot of the surgery that we do is predicated on our ability to look at the tissue blanching,
Right.
or quite honestly, just the experience that we get in doing this procedure.
So experience is huge. Come on back over here, doctor. First of all, that was fascinating what you just showed us. But one of the things I want to get at right away, you talked about all the advantages. Okay, I put my finger in there, and it was amazing, the scale, the difference, and what is it? Is it 10 times bigger?
10 times.
10
correct.
times.
Yep.
But the one thing you said that I know people need to understand is you said that one of the challenges has to do with the what you could feel and what you couldn't feel. What language did you use?
Was haptics.
Haptics.
The
What does that mean?
Haptic response. Well, in open surgery, you're able to feel how the needle, for example, goes through the tissue. In this particular circumstance, we rely on our experience as well as the excellent visualization to protect us from that particular circumstance.
So for the patient's perspective, which is what we're concerned about, is how is the patient protected there?
By the surgeon's experience.
Clearly. So the patient knows, based on that experience, how hard they're pressing and how hard not to press, right?
A robotic surgeon has that training to prevent any kind of problems from happening.
So the key is the training.
That's correct.
The key is the experience.
That's correct.
What does this do for most patients in terms of the recovery?
Well, the majority of my patients leave the hospital in 23 hours. So if I do a surgery on a Monday, by Tuesday afternoon the patient is home. That would never be the case with an open procedure. You're looking at a 3 or 4 day hospitalization at a bare minimum, and also the complications that are associated with a large open wound and other potential medical problems the patient may have.
Most patients respond well to the idea of this robotic surgery, or how much you educating them is involved in the process?
The majority of patients are delighted with the recommendation. Once in a while, a cancer patient will be concerned with the inability of the surgeon to get their hand in the abdomen to feel all around to be sure there is no other cancer. That's a rare circumstance, and if you choose your patients correctly, you almost will invariably not be in that situation.
Again, you called yourself an old dog, your words, not mine.
Correct.
More importantly, what it really means is you've seen a lot.
Correct.
For you to see this right now and to see the possibilities and the challenges, what does it mean for you moving forward in terms of treating your patients? How excited are you?
I think this is fantastic. This has been a major addition to my ability to take care of my patients, and certainly they are most grateful at the end of the day when seemingly the outcomes are the same long term with a much more rapid return to life.
And finally, the possibilities you see ahead.
I think we're going to see it in other malignancies as well.
You do?
I do. I think that it's a matter of time, but it will take time and we will see it.
Dr. Amar, thank you for joining us and sharing about this important technology and the possibilities, but also helping to educate people.
Thank you, Steve. My pleasure.
Thank you. Stay with us, folks. We'll be right back.
One-on-One with Steve Adubato has been a production of the Caucus Educational Corporation, celebrating 25 years of broadcast excellence. Funding for this edition of One-on-One with Steve Adubato has been provided by Investors Bank, the Russell Berry Foundation, Fedway Associates, Inc., PSE&G, committed to improving New Jersey's economy and strengthening its communities, the law firm of Gibbons, P.C., and by St. Peter's University, the Jesuit University of New Jersey. Promotional support provided by the Star Ledger and NJ.com, Everything Jersey, and by NJ Biz, All Business, All New Jersey. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area. One-on-One with Steve Adubato has been produced in partnership with St. Joseph's Healthcare System.